Manish Parekh to discuss with us the objectives of today's session.
Good morning, delegates, colleagues, and friends. It is always an honor and a true privilege to be up here. This is Meril's 12th course as such on this Meril Academy beautiful Oasis campus. It is as exciting for me as when I once saw this 3 years back in the making. Really a special 2 days for all of us for interacting with each other and learning from one another. This particular curriculum is designed for the audience and all of us to partake. We have a fantastic faculty. I want to thank and congratulate all of the faculty for making it here. And we're going to lead off our day with some complex coronary intervention discussions and a live case. The live case is only a few minutes away. In about 9 minutes, we're going to go to the live case session number 1. And that's going to be sure to be very exciting as a left main case. I'd like to call up our moderators. As you've met, Dr. Gambhir is away, and our expert panel, Dr. Vishwanathan from the United Kingdom, Dr. Victor Singh from South Africa, Dr. Terzic from Bosnia, and Dr. Studenkin from Slovakia. Please come up and join us here as we will launch our day. So I'm going to take a few minutes to sort of highlight the objectives of why we all are here in cardiovascular disease to talk about interventional cardiology here on the Meril campus. And this is really about exchanging ideas. We're not revascularized. So we know about the anatomic considerations. We've learned that for many years. But we're now coming into full function with respect to the ventricular function and hemodynamics of our patients. We at Columbia, through one of our fellows who's now practicing at the MGH, over the last 2 years, looked at a Medicare database of patients involved and admitted with a heart failure diagnosis as their principal diagnosis. This was from 2010 to 2014, over 67,000 patients who had come in with a new heart failure primary diagnosis. And baseline coronary disease was very low during their index hospitalization. But after these patients got admitted, their apparent known coronary disease was no different, slightly less than 27%. But they're very good. We are all very good at doing extremely significant non-invasive workups, echoes, stress echoes, nuclear stress tests. But where is the cardiac catheterization? And we published this, and we found that a preponderant number of patients never actually come for even a diagnostic cardiac catheterization with an admission of congestive heart failure. If you look at the annual utilization of coronary revascularization, this is over 75 million patients. 52% of the patients diagnosed with CAD undergoing cath are not even revascularized. And patients diagnosed with congestive heart failure, 56% of these patients are not revascularized. And this has been an ongoing issue we find in the United States just because we're not being aggressive enough at looking at these patients. We know that appropriate PCI in patients with viability and ischemia improves ejection fraction, which we know will improve their potential prognosis. So we have both hemodynamic and ventricular function, anatomic considerations, but then comes the patient comorbidities. They're too sick. We have an aging population throughout the United States, no different in Asia, no different anywhere else in the world. And if you look at this past publication from Waldo in Circulation in 2014, among 1,000 patients with left main multivessel disease undergoing PCI at the Mass General Brigham over 3 years, 218 were deemed ineligible for coronary bypass. And this ineligibility was associated with a 6-time greater odds of in-hospital mortality. And these are the patients that we typically see based on age, renal function, lung disease, systolic dysfunction, malignancy. Half of them are due to age or comorbidities. Sounds familiar? It sounds familiar to me where I practice, because these are the types of patients that get referred in to be seen by us in the city institution. And if you look at that, if you look at the Kaplan-Meier estimates comparing long-term mortality among those with surgical anatomy undergoing PCI stratified by documentation, surgical ineligibility portended a very, very poor prognosis. So this is the risk treatment paradox, and this is what we call the complex, high-risk, and indicated patient. These are the patients that many of us who have been doing this for several decades feel like we've been doing this for many, many years. But I think it's an important adjunct to know that in your system, whichever that hospital system that is, that you have to have a team that can manage all the needs of the patient when they present. And we do see in the United States a clear underpenetration and undertreatment for these patients. So the summary is the patients are more complex because of their age, their comorbidities, their anatomy, the anatomy including calcific disease, bifurcations, left main disease, chronic total occlusions, and multivessel disease, and poor left ventricular ejection fractions. And this prevalence is increasing throughout the world. And we've seen that and documented that with respect to calcific disease in the patients, knowing that patients with multivessel disease undergoing PCIs is increasing. And the message is that this large underserved patient population can benefit from revascularization. And rather than us, or many of us, focusing on just low-risk patients who may be easy to treat, these patients who are more complex to treat, who need complete revascularization, should be enrolled in our laboratories and should have skill sets amongst our team to be able to manage. So the core skills are intervention, CTO, case selection, and mechanical circulatory support, which has become a huge part of the adjunct of what we've been doing for our patients in the United States. And then having a team. We at Columbia have a shock team, which includes a CT surgeon, a heart failure shock cardiologist, and an interventional cardiologist, 365 days of the year. And then obviously we need to continue to learn from each other, publish, and do research. And these are the aims of the program, is to equip the interventionalist with the necessary skills to handle any coronary case, be a supportive team member, learn to manage new hemodynamic support technologies, and apply our skills to revascularization. And I'm hoping that part of what we will do here at Chapter 12 Meril will be to learn from each other, looking at some of these subsets of patients, and with a case-based format, teach each other what we've been doing and how we've been doing it, so that we can further the field and take better care of our patients. This is our team in the United States at Columbia. It does not ever be one person. There's another 25 people on the floors that help us take care of these patients, and this is essential to having success. And I think from that, we'll go right to our live case and then continue with the lecture a little bit later. We ready? The live case has been delayed by 15 minutes. Okay.
So Manish, I think while you get on to do the second part of your lecture, that's a wonderful segue of talking about high-risk complex patients. And let's take any questions from the audience as well as from our panelists to see what are the definitions of CHIP in your region. How do you come up with the selection of cases, and how do you support these patients, and what sort of gear do you have in the cath lab, or team do you have in the cath lab? Let's start with Girish in the UK.
Thank you. The CHIP cases are becoming a norm, and you rarely find a type A lesion nowadays. It has got huge implication on the trainees who want to train on the simpler versions. So when you plan a day, you have to plan for a CHIP case. You don't know who is coming through the door. It involves one, patient problem, patient-related comorbidities, diabetes, LV dysfunction, cardiogenic shock, presence or absence of hypotension in addition. Number two, it's a lesion problem. Is it calcified? It is a CTO. Is it a bifurcation? Is it a left main, or it's a left main equivalent? The third is that procedural consideration, what techniques we are going to use, what bifurcation techniques we are going to use, what mechanical support you have to use in these patients to get them a good outcome. When I mean a good outcome, it should be a day 0 good outcome, it should be a day 30 good outcome, and it should be a 12 months good outcome as well. When we plan the procedure, we have to plan for a long-term success rate as well. Thank you.
Hello, in my country, Bosnia, actually CHIP patients are becoming reality, but till now, frankly speaking, it's usually treated by surgeons. But, you know, of course, many of patients are treated by us, but limited resources by main reason because we cannot do more such type of cases. That causes, on the other side, lack of experience and no high volume operator, which can cause, of course, maybe worse outcomes for the patients. But situations are changing last years, and we are doing high complex cases like left main, like complicated bifurcation, CTOs, and et cetera. Thank you.
In my country, I'm from Slovakia. In my country, up to 70% of patients treated by PCI are acute cases, acute coronary syndromes in the cath labs. So we do everything we can, but as you mentioned, over the last years the guidelines changed, and we have a new materials, new stents, and new techniques, and so on. And PCI is going to be as good as bypass surgery in many indications. I said as good as, not better. So that's why I think proper practice in a cath lab depends on the surgery aggressivity in the same field, in the same hospital. If you sit together with the surgeons, they need to operate anyway. And once the case is complex, and then he said, okay, but you are as good as we are, even rate of hospitalization is lower after bypass surgery. So many times we agree and we tell them, okay, you can do it. Even we are sure we can do it as well. So it's an approach. We do it, but many times we prefer to do it by surgery, especially if it is diabetic, if it is a more complex disease, left main, including next vessel.
Yeah. I think that there's no doubt that we know the data for multivessel disease and diabetics, and we'll do a little deep dive on that later. But it's when the surgeon does not want to operate or can't operate. These are the types of patients that are growing, and these are the ones that we really need to be able to tackle. So let me just jump into my case because we still have a few minutes, and then we will get to the live case. So here's a patient, very typical. This is a patient of mine. It's a 49-year-old gentleman with ischemic myopathy, heart failure, class 4, angina class 3, who is referred from a small suburban hospital in Queens, the borough of Queens in Manhattan, to our heart failure service for possible transplant. This gentleman had an anterior wall MI 20 plus years ago. At that time, at a young age, had a CABG with a lima to the LED, a vein graft to the OM. Since then, he's had a defibrillator with a recurrent VT with paroxysmal AFib, and he's a prior smoker with active diabetes, uncontrolled A1C. Here is his A1C is 8.2, his creatinine is 0.9. He's got a high BNP. His echo shows a left ventricular diastolic dimension of 6.9, an EF of 20% with a dyskinetic apex, with everything else moving, and in a viability study that shows a large apical defect, but moderate intensity reversible defects in the septum, anterolateral, and inferior-lateral walls. So let's go to the film. And this is typically what these patients look like. Here's his arteriocaudal of the left system. LADs occluded, circ marginals occluded. There's a big defibrillator, tight left main with very faint collaterals left to right, and the AP cranial, and very little to no septals to speak of. tight left main origin of the circ. The OM is diffusely diseased. Here's the right coronary, which is a chronic total occlusion of a dominant right with bridging collaterals from the prox to the mid. Here's an AP cranial, so you get a sense of what the distal target is. And you've got right to right collaterals. I like to do this right lateral because you really can see the course of this, and you see how profound these bridging collaterals are. And here's his internal mammary going to the LAD with a subtotal lesion. So the question is, how is this guy even alive? And you can understand why he's in VT, heart failure, and also having angina. And here's a left lateral of the internal mammary anastomosis, which shows you that he's got essentially a CTO of the anastomosis to the LAD. His vein graft to the circ marginal we know is occluded. The right coronary. And for effect, here's his ventricular graft. His right heart pressure is initially at a
Dr. Kumar, good morning.
Consideration was, do you do a reoperation in this man?
Sir, are we ready for the case?
Do you list him with mechanical support, or do you buy him time with a percutaneous option? And I'd like to ask the panel,
is there a second opinion doctor with you as well?
do in your
Can I have a
individual
mic test for him?
countries? And this is a 49-year-old man with 2 teenagers.
Can you hear me as well? If Dr. Anupam can hear me, can you please
We are
respond?
currently recruiting to a study called Revived Study, which will answer an evidence for this kind of patients. Revived Study is run by Viveka Pereira from King's and Imperial. It is patients with established heart failure, viable territory subtended by an artery which has got severe disease which is percutaneously treatable. And these patients are randomized to standard medical therapy plus devices versus PCI plus devices plus medical therapy. That study we have recruited 2/3. We are waiting for the results, and we will see whether PCI electively in these patients will improve outcomes. Here we are slightly different. This guy is in a proper pickle, and any options are going to be high risk. Treating him with standard medical therapy, we tried long ago, it's not going to work, he's not going to live long, his immediate mortality risks are higher. Percutaneous options with mechanical circulatory support, especially stages, start with a circumflex artery to improve some circulation, have some money in the bank, and then think of the CTO with an established, experienced CTO operator to tackle the right, will give him a better option. What are we going to do about the lima? It's a question that we have to answer. Redo surgeries in these patients. The outcomes are very poor. There is up to 40% on-table mortality, or during the first 2 days, the patients will not come out of the ITU. I think redo surgeries are very, very high-risk options. Cardiac transplant in these guys. I'm a bit skeptical about acute heart transplant in patients, young patients